Yes, I'm there. Okay. This patient with progressive hip pain in the set this patient with progressive hip pain in the setting of chronic glucocorticoid use, dorsocervical fat pad, moon faces, glucocorticoid myopathy, and has typical features of osteonecrosis, avascular necrosis of the femoral head. Osteonecrosis occurs in disorder that disrupt in the circulation of the bone through microocclusion, abnormal endothelial function, or increased interosseous pressure. It is a common complication of long-term glucocorticoid use, possibly due to effects on osteocytes or abnormal plasma lipid levels causing microemboli. Osteonecrosis causes bone and marrow infarction. Osteonecrosis causes bone and marrow infarction. Abnormal bone remodeling subsequently results in abnormal bone remodeling subsequently results in trabecular thinning and collapse over months to years. Osteonecrosis of the femoral head is characterized by pain in the groin, thigh, or buttock. Pain in the groin, thigh, or buttock that is worsened by activity and relieved by rest. Progression of the disease can lead to reduced range of motion. Progression of the disease can lead to reduced range of motion, usually abduction and internal rotation, wrist pain, and joint instability in the first few months. X-ray are often normal and MRI is most sensitive. Age age in between 2 to 8. Ultrasound, ESR CRP normal. Ultrasound shows a bilateral effusion of both hip. There is limb pain in the hip. refer to the knee, limited internal rotation. Just you give NSAID for 2 to 4 weeks, it will resolve. And there is usually no recurrence. No, no, it's not JIA. Where is the yes, it's transient synovitis. In GIA, there may be joint count. It is only knee pain, so only one joint. In GIA, one or more than one joint is needed for systemic GIA to happen. You need one arthritis for more than one joint. Okay, so this patient, this child with knee pain has limited hip mobility and bilateral hip effusion consistent with transient synovitis. Transient synovitis, a common self-limiting intermittent inflammatory hip condition that occurs in children 3 to 8. The etiology is unclear but often involves post-viral or less commonly post-traumatic gymnastic classes, joint inflammation. In some cases, no preceding trigger is identified. Presentation include a well-appearing child with acute hip pain or referred knee pain. Knee examination is normal as in this case, and the patients often hold the hip flexed, abducted, and externally rotated. Hip flexed, abducted, and externally rotated to relieve pressure in the joint space. Limping is common, although patient can usually bear weight on the affected leg. Fever is typically absent or low grade, and lab evaluation C-reactive protein WBC count is usually normal. Ultrasound reveals small unilateral or bilateral effusion. Ultrasound reveals small unilateral or bilateral effusion even when symptoms are confined to one hip. Treatment of transient synovitis. Treatment of transient synovitis is conservative, NSAID, anti-inflammatory medication, and symptoms generally resolve within days to weeks. Okay. Wait. Oh,
Damn it.
okay. Median nerve compression can happen in the forearm too, but it is other symptom like pronator teres symptom. In here, like look at uh, uh, the highlighted point you have done. So the pink one, there is weakness in the thumb opposition, and the thumb, mid index finger and middle finger, there is decreased sensation. So it looks like more in the wrist than in the forearm. Okay, first look at the pronator teres syndrome. In pronator teres syndrome, what happens? In here, there is median nerve compression in the forearm, can cause like option E. Yes, E first. Median nerve compression in the forearm, pronator teres syndrome. Pronator teres syndrome can cause forearm pain and sensory loss in the palmar aspect of first three digit, like in here, like in this stem. However, additional sensory loss over the lateral palm and the thinner eminence would be expected. So lateral palm and the thinner eminence would be expected due to involvement of palmar cutaneous branch. Got it? So for pronator teres syndrome to happen, you need all these sensory loss like thumb, index finger, middle finger, like in this stem. But along with, we need loss over the lateral palm and thinner eminence would be expected due to involvement of the palmar cutaneous branch. Okay, now look at the carpal tunnel syndrome. This patient has pain. This patient has pain and decreased sensation in the hand. Decreased sensation in the hand consistent with carpal tunnel syndrome. Carpal tunnel syndrome is caused by compression of carpal tunnel syndrome is caused by compression of the median nerve, as it passes deep to the flexor retinaculum. Compression of the median nerve as it passes deep to the flexor retinaculum in the wrist, and is common in patients with diabetes mellitus, as in these individuals with repetitive forceful use of the wrist and hand. Manifestation of CTS include paresthesia, pain, and sensory loss over the palmar aspect of first three digits, sometimes lateral aspect of the fourth. Uh, Patient may also have referred pain into the lateral palm, forearm, even in the upper arm. However, palmar cutaneous branch of the median nerve passes through the carpal tunnel, and carpal tunnel sensation over the thinner eminence typically remain intact. Sensation over the thinner eminence typically remains intact. Sensation over the thinner eminence typically intact. Eminence typically remains intact. Okay. In the clinic, symptoms may be provoked by percussion. Symptoms may be provoked by percussion, tinel test, and manual compression darken test over the nerve by forceful flexion of the wrist phalanx test. Early CTS typically has intermittent course with symptoms often worse at night. However, manifestation can be highly variable. Patients with severe disease, as the disorder progresses, symptoms may become persistent and usually associated with motor features, thinner atrophy, weakness of the thumb, abduction, and opposition. Okay. Okay, this is radial head subluxation, nursemaid's elbow. This 4-year-old, this 4-year-old is holding her forearm. This 4-year-old is holding her forearm in pronation and not moving the extremity, not moving the extremity after being swung by arms. After as being swung by arms, these findings are consistent with radial head subluxation. These findings are consistent with radial head subluxation. Nursemaid's elbow, a common injury in preschool age children. Can I call you 5 minutes later?
Yes.
Okay,
Yes.
okay.
Depends on how you do. I want to say metastatic cancer.
Sorry. That is another problem. Osteoporotic compression fracture actually, okay, look at the option E first. This is very confusing. Other we can exclude. Osteoporotic compression fracture can cause midline spinal tenderness. However, osteoporosis is uncommon in men, particularly those aged less than 65. Compression pathologic fracture in this patient, if present, compression fracture in this patient, if present, is more likely to be due to metastatic deposits, and pain can be present at rest. Okay. After 65 for men, and for women it can be before 65 because osteoporosis can happen after menopause in for female. Okay. Vertebral metastasis should be suspected in a patient with back pain and a current or recent history of malignancy. Characteristics features include pain that is progressive, worse at night, unrelieved by rest, associated with focal vertebral tenderness, acute neurologic deficits, Cauda-Equina syndrome, unexpected weight loss, hypercalcemia may occur, bony tenderness, much more common than primary bone tumor. The most common tumors to metastasize to bone include prostate, breast, kidney, thyroid, non-small cell lung cancer, as well as non-Hodgkin lymphoma, patient with a history of non-small cell lung cancer. Patient with a history of non-small cell lung cancer has back pain that is worse at night and focal vertebral tenderness on examination. Although his initial PET scan was negative a year ago, his history of high-risk malignancy and the characteristics of pain make metastatic bone disease the most likely diagnosis. Okay. Yes. Musculoskeletal malignancy, infectious MMI, musculoskeletal mechanical pain, normal neurologic examination, paraspinal tenderness, normal neurologic examination, paraspinal tenderness, radiculopathy, radiation below knee, positive SLR, neurologic deficit, spinal stenosis, pseudo-claudication, relief with leaning forward, compression fracture is osteoporosis, onset following minor trauma, malignancy is metastatic cancer, age more than 50, worse at night and unrelieved with rest. Infectious is osteomyelitis, discitis, abscess, recent infection, or IV drug use, fever, spinal disease. Age more than 60. Uh, yes, yes, obvi obviously NSAIDs. Management of the osteoarthritis, look at this flow chart. Non-pharmacologic management, exercise, weight loss. If symptom persist, topical or oral NSAID topical or oral NSAID as needed. Consider duloxetine or topical capsaicin. If symptom persists, or significant impairment, surgery if possible. Chronic pain management, not surgical candidate. Okay. This uh, this patient has chronic joint pain. This patient has chronic joint pain, periarticular bony enlargement, a bland synovial effusion, low synovial leukocyte count, no crystal, finding consistent with osteoarthritis. Risk factor include advancing age, obesity, diabetes, and prior joint injury. Patients typically have no or patient typically have no or mild inflammatory feature, erythema, morning stiffness, X-ray symptoms, systemic symptoms. Examination can show crepitus and symptoms and sometimes a small effusion. The diagnosis is often confirmed with X-ray, which reveals narrowed joint space, osteophyte, and possible subchondral sclerosis. Initial management of osteoarthritis should emphasize non-pharmacological measures like including exercise, weight loss, activity modification. Exercise, weight loss, activity modification. NSAIDs, diclofenac are the medication of choice. NSAIDs and diclofenac are the medication of choice for chronic OA pain, relief, and can be given in oral or topical form. NSAID should be used with caution in patients with history of peptic ulcer, normal renal, peptic ulcer, coronary artery disease, CKD. Although diabetes is a risk factor for CKD, this patient has normal renal function, so use of steroid NSAID is appropriate. Yes, it's not that. uh, there, look at he has strep pharyngitis, and then he started oral penicillin. Then the rash on his second of the last day of the oral penicillin, this diffuse rash is happened. No, it's not anaphylaxis. In anaphylaxis to happen, you need a respiratory complaint. There may be urticaria. This rash is just diffuse. Why you have choose scarlet? Boiled lobster. Have you eaten lobster? Okay. No, I haven't tasted any sort of seafood. Okay. This boy. Reaction. Okay. This boy took penicillin for several days. This boy took penicillin for several days and then developed symptoms: fever, urticaria, of serum sickness, light reaction. Although The presentation of serum sickness-like reaction closely resembles serum sickness. The underlying cause differs. Serum sickness, classically triggered by exposure to foreign protein antitoxin, murine, or chimeric monoclonal antibodies due to high titer immune complex generation, immune complex deposition, and excessive classic complement cascade activation. In contrast, serum sickness-like reaction is not associated with immune complex or complement activation. Although the exact etiology is unclear, cases may reflect drug-related heptin formation or direct lymphocyte hydrophysicity triggered by exposure to beta-lactam, cefaclor, penicillin, or trimethoprim sulfamethoxazole drug. Both serum sickness and serum sickness-like reaction present with fever, arterial rash, arthalgia. Fever, arterial rash, intensely pruritic plaque that spared the mucous membrane and typically persist more than 24 hours. Arthalgia, polyarticular joint pain that worsens with movement and palpitation, and signs of arthritis, overlying erythema, warm edema are not typically present but may occasionally occur. Some patients may have mild proteinuria or diffuse lymphadenopathy compared to serum sickness. Serum sickness-like reaction is usually less severe, low-grade fever, less likely to cause systemic manifestation, and is more common in children. Manifestation typically begins within 5 to 14 days of medication initiation and resolve spontaneously with medication discontinuation.
Rapid detection of the
Okay. Initially, it looks like alcohol withdrawal, but it is not. Okay. Now look at the option A first. Sudden cessation of alcohol intake may lead to severe alcohol withdrawal Sudden cessation of alcohol intake may lead to severe alcohol withdrawal, which can cause confusion and autonomic hyperactivity tachycardia. However, focal neurologic deficit, left arm weakness, and hypoxemia are not expected. So, focal neurological deficit and hypoxemia take the diagnosis otherwise. Okay. This patient worsening respiratory status and neurologic function, neurologic dysfunction 2 days after a femur fracture. 2 days after a femur fracture are concerning for fat embolism syndrome. Fat embolism syndrome when fractures of a large marrow or rich bone or large marrow rich bone femur releases fat into the venous circulation. These may lead to mechanical disruption of the capillary blood flow both in the pulmonary and systemic circulation, which the fat emboli may enter as microemboli, small enough to pass through the pulmonary circulation or via a shunt pattern foramen oval. Microvascular obstruction in the pulmonary capillary can cause respiratory distress, tachypnea, hypoxemia. In the systemic circulation, brain skin cause neurologic dysfunction. Brain skin can cause neurologic dysfunction, tachypnea, hypoxemia. In the systemic circulation, it can cause neurologic dysfunction and or petechiae. Neurologic dysfunction may range from confusion, visual field defect, or focal deficit, left arm weakness to seizures, obtundation, or coma. Fat embolism syndrome is typically diagnosed clinically. However, MRI of the brain is sometimes used and can visualize multiple small hyperintense foci consistent with cerebral fat embolism. Okay, sorry.
EM.
Cocaine possibly used with alcohol. Cocaine possibly used with alcohol. A powerful vasoconstrictor that can cause cerebral vasospasm. Although the vasospasm may manifest as confusion or stroke-like symptom, it typically occurs at the time of the intoxication rather than 2 days after. Blunt head trauma can cause DAI, diffuse axonal injury, representing shearing of the white matter tract. Although neurologic symptoms can vary from mild headache and nausea to severe coma, they typically present immediately mm, after 2 days after injury and may cause diffuse or focal deficits. Okay. He is sexually active with multiple partners. So looks like DGI, even if gram stain is negative. Okay. This patient has fever and purulent monoarthritis of the right wrist with no recent trauma and no evidence of synovial fluid, crystal, or organisms on microscope. The constellation of the features in an individual at risk for sexually transmitted infection, multiple sexual partner raises suspicion for disseminated gonococcal infection. DGI typically presents with either a triad of migratory arthalgia, tenosynovitis, and pustules, or purulent oligo or monoarthritis. Manifestations of arthritis are typically begin suddenly and are marked by joint swelling and pain. The knees, wrists, and ankles are most often affected. Fever and malaise are frequently present. The diagnosis of DGI, diffuse gonococcal infection, requires sampling from multiple areas because Neisseria gonorrhoeae is a fastidious organism, and culture results are frequently negative. Two sets of blood culture should be obtained, and synovial sampling required when joint effusion is present. Synovial fluid count usually 50,000 with a preponderance of neutrophil, but organism may be absent on gram stain. Synovial fluid should be sent for nucleic acid amplification testing or culture mucosal sites, rectum, urethra, throat should also be sampled, and specimens sent for NAT. Although patients with DGI do not typically have symptomatic infection at the portal of the entry urogenital tract, mucosal NAT is positive and can provide presumptive diagnosis. Okay. Palpable step of sign, very classic for one. Like if there is forward displacement of one vertebra. So if we palpate, there is a step of sign in the lumbosacral. Okay. In adults, back pain. In adults, back pain is common and is usually benign. In children, back pain is often due to benign musculoskeletal condition or trauma, but a careful evaluation exclude other causes should be performed. These patients' back pain, particularly with lumbar extension, back pain with lumbar extension and examination findings are consistent with Spondylolisthesis. Spondylolysis represents with fracture, pars fracture. Spondylolysis represents pararticularis defects fracture that are often due to overuse, injury, fatigue fracture, and can be unilateral or bilateral. Spondylolisthesis is characterized by forward slip of a vertebral body, usually L5, and develops in patients with spondylolysis who have bilateral defect. It is more common during adolescent age 10 to 19. Adolescent 10 to 19 growth spurt due to increasing physiologic lumbar lordosis, exposing L5 vertebra, and decreasing bone mineralization. Athletes with repetitive back extension and rotation, gymnasts and divers are at greatest risk. In addition to progressive low back pain, that is worse with lumbar extension. The shifted vertebra also impinge on the shifted vertebra also can also impinge on the spinal cord and cause radiculopathy radiating pain, numbness, weakness. In advanced cases, a palpable step off and the area of vertebral displacement is characteristics of examination. Okay, I did wrong. Okay, this patient has tophaceous gout affecting the olecranon bursa. The olecranon bursa is a fluid-filled synovial sac between the olecranon process and the skin that elevates friction at the bony prominence. Gout can affect superficial bursa olecranon prepatellar in multiple ways. Acute bursitis in gout flare presenting with erythema, warmth, swelling. Chronic bursitis uh, presenting with large, round, fluctuant effusion. Bursal tophus manifests as a slowly enlarging hard mass, as in this patient, sometimes with mild inflammatory changes. Acute bursitis is painful due to rapidly escalating inflammation. In contrast, Chronic bursitis and bursal tophus typically have minimal or no pain because of because the accompanying inflammation is generally indolent. Tophi are large aggregates of the monosodium urate monohydrate crystal may form in the nearby humero-ulnar joint or other types of soft tissue ligament joint. Tophi often trigger a chronic inflammatory response in the surrounding tissue bone, resulting in bone erosion with overhanging edges of cortical bone on imaging. Urate is intrinsically radiolucent, but urate is intensely radiolucent but can become radio opaque when calcium precipitates with urate crystal as tophus. Risk factor tophi formation include chronically untreated gout, CKD, due to decreased uric acid excretion. Conversely, chronic hyperuricemia can cause or worsen CKD due to nephrolithiasis and urate deposition in the renal interstitium, urate nephropathy. Okay.
Further similar episodes.
Okay, this patient has sudden onset severe pain in the first metatarsophalangeal joint podagra consistent with acute gout. Initial treatment can include NSAID, indomethacin, glucocorticoid, colchicine, urate-lowering medication, allopurinol, and febuxostat are indicated in patients with recurrent attacks or complicated disease profile, uric acid, kidney stone. This patient is having his first attack and does not require urate-lowering medication. However, he has multiple risk factors for recurrent gout, obesity, hypertension, insulin resistance, should be counseled on lifestyle modification to reduce risk. Weight loss and caloric restriction can reduce the risk of recurrent gout. In addition, specific dietary changes are recommended, and the risk attacks is increased with intake of red meat, seafood, but is reduced in diets emphasizing protein from vegetarian or dairy sources. Low fat dairy sources. Risk is increased with heavy intake of beverages and foods containing fructose and other refined sugars. Heavy alcohol intake, especially from beer or distilled spirit, is associated with increased risk of gout. Ethanol increases the uric acid production and may also decrease renal elimination of uric acid. Okay.
5-year-old boy brought to the developing each other.
Okay, it's IgA vasculitis or HSP, Henoch-Schönlein purpura. This patient likely has HSP, Henoch-Schönlein purpura, an IgA mediated small vessel vasculitis. An IgA mediated small vessel vasculitis that occurs most commonly in school-aged children. Classic manifestation include non-blanching palpable purpura on the legs and buttocks, lower extremity arthralgia or arthritis, which can result in refusal to ambulate, abdominal pain, and renal disease, hematological proteinuria. Symptoms are often preceded by mild upper respiratory infection, as seen in these children. Typically, abdominal symptoms are caused by localized bowel wall inflammation, include colicky, diffuse pain often associated with nausea and vomiting. However, severe abdominal pain in HSP should prompt further workup for gastrointestinal complication, most commonly intussusception, intestinal edema, and bleeding associated with HSP can also can act also a lead point or intestine to telescope into the adjacent bowel. In contrast to most in contrast to most pediatric cases of idiopathic intussusception, which is typically ileocholic, intussusception is in HSP is usually confined to the small bowel ileoileal. Intussusception is typically present with severe episodic abdominal pain and current jelly or bloody stool. Uh, although ileocholic intussusception are treated with air or contrast edema, ileoileal intussusception that do not reduce spontaneously often require surgical management. Yes, IgA vasculitis, enoxadenal purpura, perivenular leukocytoclastic neutrophils, and monocyte vasculitis, deposition of IgA C3 and fibrin in small vessels. Clinical manifestation, classic finding, palpable purpura, petechiae on large lower extremity, petechiae on lower extremity, arthritis or arthalgia, abdominal pain, intussusception, abdominal pain, intussusception, renal disease similar to IgA nephropathy, other findings, scrotal pain and swelling. Normal platelet count and coagulation study normal to increase creatinine. Hematuria are with hematuria with or without RBC cast or proteinuria. Supportive management, supportive care, hydration and NSAID for most patient, hospitalization and systemic glucocorticoid for severe symptoms. What is your diagnosis? Wait, what is your diagnosis? Limited abduction and external rotation. Uh, and external, there are two differential. If there is problem like pain in abduction and external rotation, it is rotator cuff tendinopathy. If there is limited or weakness in shoulder abduction or external rotation, it is TR. And for TR, we need to do MRI. like rotator cuff tear, we need to do MRI. Yes, tear comes with weakness, like limited abduction and external rotation means it is weakness. Yes. If it is pain, then it is tendinopathy. And in rotator cuff tear, there is test like drop arm test or empty can test. This test can be done to diagnose rotator cuff tear, and MRI is confirmatory. Okay, this patient has post-traumatic shoulder pain, limited post-traumatic shoulder pain with limited abduction, most likely due to rotator cuff tear. Rotator cuff tears are most common in patients aged more than 40, often after a fall on outstretch and often after a fall on outstretch, and patients typically have pain at the lateral shoulder that is worsened with raising the arm of overhead and with external rotation and abduction. Examination shows drop arm sign, inability to smoothly control shoulder abduction, and weakness in external rotation. Passive range of motion is normal. Rotator cuff tendinitis may also present with pain on abduction, but tendinopathy without tear does not cause weakness. X-ray of the shoulder in rotator cuff tear is often performed as an initial study to rule out the fracture. In large chronic tear, it may demonstrate a migration of the humeral head, but it has low sensitivity for confirming the diagnosis of an acute tear. Okay, okay, am I right? Sorry. Yes, MRI can visualize the soft tissue and actively rotator cuff tear. Treatment of acute tear usually involves surgery, with best result if performed within 6 weeks within the injury.
Mm. Yes, I did.
Okay, it's Paget's disease of the bone. Okay, this patient has cortical. This patient has cortical skull bone thickening associated with headache and hip pain. In older individuals, this presentation suggests paralysis of the bone. Paralysis of the bone is characterized by disordered, uh, excessive disordered remodeling and can lead to focal growth, hard head, hard hat, feeling tight, weakness, or fracture. Cranial bone involvement may cause headache, frontal losing, cranial nerve impingement, vertigo, hearing loss. Increased blood flow to the phagetic lesion can decrease the perfusion of the cerebral cortex. Vascular still manifestation as neurologic deficit or global cognitive decline. Involvement of the spine, spinal stenosis, radiculopathy, long bones, and bone pain, arthritis of adjacent joint is common. Elevated serum ALP, reflecting increasing bone turnover, may be the only manifestation. Imaging X-ray CT scan show thickening of the cortical bone and trabecular bone, osteolytic lesions early or mixed osteolytic osteoblastic lesions later. Asymptomatic patient with minimal disease activity may be observed without treatment. However, systemic manifestation patients, those with involvement, high risk fracture, skull. Okay, bisphosphonate suppress the bone turnover are the preferred therapy. Okay, okay, can we stop here?
Yes, we can.